People keep joining, and then I'll start in a few seconds so we have time. I want to do the introduction and then we can get going.
Sounds good.
Okay, I'm going to go ahead and get started with our introductions. So good afternoon. My name is Wendy Brunetto, and I am the manager of population health here at Yale Health. We're here today with Dr. Joanne Knudsen, who is the chief of obstetrics and gynecology at Yale Health, and our speaker, Dr. Liva Andreeva, who is an associate professor of clinical radiology and biomedical imaging and breast imaging fellowship program director with radiology and biomedical imaging. She received her graduate degree from Yale University in 1996, her undergraduate degree, and received her medical degree from Albany Medical College in 2000. She completed an internship at the Hospital of St. Raphael in New Haven, did a diagnostic residency at Bay State Medical Center in Springfield, Mass., and then returned to Yale University to complete her fellowship in breast imaging. Dr. Andreeva has been a diagnostic radiology faculty member since returning to Yale and is passionate about resident and fellow education, as well as educating the community about the benefits of undergoing breast screening. So today you're going to learn more about the benefits of screening mammography and the added benefits of tomosynthesis in mammographic screening for breast cancer, the benefits of screening in the U.S. For those women with dense breast tissue, and then screening patients who are at elevated risk of breast cancer. So thank you, everybody, for coming, and I'm going to turn it over to Dr. Andreeva.
Yes, hello. I'm Liva Andreeva. It's a pleasure to be here and talk to you about a topic that's very important. And it's been an honor and a pleasure to take care probably of some of you who are here today. So today we'll talk about screening for breast cancer, who, when, and how. So the topics that we'll look at today, we'll talk about some breast cancer facts. We'll talk a little bit about brief history of screening mammography, the current screening recommendations, screening tools that we've got, 3D mammography, ultrasound, and MRI. And we'll talk about screening patients at elevated risk of breast cancer. So, as most of you know, breast cancer remains a major worldwide health problem, and in the U.S., a popularly quoted figure is that about 1 in 8 women, about 12.5%, will develop breast cancer at some point during her lifetime. And in 2022, we had 288,000 cases of invasive breast cancer diagnosed in the US in women, and about 51,000 cases of DCIS. So that is like early breast cancer that arises in the breast ducts. And some men, also about 2,710 cases of breast cancer has been diagnosed in men in 2022. For men, the risk of breast cancer is significantly lower, about 1 in 833 men. It is the most common non-skin cancer found in women and the second leading cause of cancer-related death in women. So it's second to lung cancer. Lung cancer is the first. And in 2022, about 43,000 women still died from breast cancer. The most significant risks of breast cancer are, a couple of them, unfortunately, are something that we can't change. One of them is being a woman, and the other is getting older. It is also true that about 85% of breast cancers occur in women that don't have any significant family history or any significant apparent risk of breast cancer. And about 10% of breast cancers that we diagnosed are linked to genetic mutations. So most breast cancers are what we call sporadic, meaning that they are not linked to genetic mutations. So clues that a hereditary breast cancer may be present. So if you or a first-degree relative, which means sister, mother, brother, father, daughter, son, if they have, or yourself have any of these conditions, so ovarian or fallopian tube cancer at any age, breast cancer diagnosis at or before age 50, or before menopause, bilateral breast cancer at any age, male breast cancer, so for instance, breast cancer in father, triple negative breast cancer. This is a type of breast cancer that tends to be pretty aggressive and is not linked to hormone expression. Breast cancer at any age and Ashkenazi Jewish heritage, or if you have more than one relative with breast, ovarian, fallopian tube, so again, first degree relative, prostate, pancreatic, and melanoma. Again, it doesn't necessarily mean that you have a mutation, but it's just a reason to consult with your physician and investigate. Genetic mutations that are associated with elevated breast cancer risk. So there are some genetic mutations that for which are render the patients very at risk to develop breast cancer. So some of these you may know about. So the BRCA1 and 2 mutations, those are probably the most famous ones, but there are a whole host of other ones that are associated with significantly increased risk of breast cancer. There's the TP53, Li-Fraumeni, P10, Cowden syndrome, and there's some other ones, Peutz-Jeghers. And then there are some a little bit less well-known ones that are also not as high a risk as BRCA, but also significant risk. And these type of mutations, patients who do have the clinically significant deleterious mutations in these genes benefit from enhanced screening regimens. So we'll talk a little bit about history of breast cancer mortality and the advent of screening mammography. So from 1975 to about 1990, breast cancer mortality rates in US women, United States women, were kind of slightly climbing, about 0.4% per year. But since 1990, breast cancer mortality rates have fallen significantly, occurring at about a rate of about 1.8 to 3.4% per year. And this is attributed to increased use of screening mammography as well as improved breast cancer treatments. And about 384 up to 6, over basically 500,000 breast cancer deaths may have been averted due to screening and improved treatment for breast cancer. So this is a nice chart, which shows, so up to about 1990, when screening mammography became a bit more prevalent and more widely used, gradually there was a decline in mortality of women due to breast cancer. And it does appear that screening mammography reduces mortality in combination, of course, with improved treatment, reduces mortality about 52% overall compared to women who are not screened. However, mammography does remain to be somewhat underutilized. In 2015, only about 65% of women in the United States had had a mammogram within the past couple of years. So how did we get here? How was screening mammography, basically, how did it become so widely used and how did it come about? Mammography actually was started in the late 60s, and through the 70s, there were several trials, clinical trials. Some of them were in the United States. This was the Health Insurance Plan of New York, and there were several Swedish trials in Sweden. The reason Sweden was chosen was because they actually have this electronic medical record system that goes back. They are very good about tracking patients. There are a couple of Canadian trials, English trials, which basically showed that if you screen women, many of them were screened at various intervals, not necessarily yearly, but regularly. And basically, they demonstrated that there was a 24% mortality reduction in women that were invited for screening, which was significant. And there were a couple of outliers, but mostly showed this figure. And there was a tremendous Canadian study, which was involved quite a long time interval, nearly 20 years, looked at a large amount of women, 2.8 million women, and basically compared breast cancer deaths in women who had screening mammograms to those that had not. And showed, again, a pretty dramatic decrease in mortality in women who had screening mammography, so 40%, very significant. And another interesting data point was that they did a breakdown by age. So women 40 to 49 years had a 44% reduction in mortality with screening. Women 50 to 59, 40% reduction in mortality, 60 to 69, 42% reduction in mortality, and also somewhat older women, 70 to 79, still had a very dramatic reduction in mortality of 35%. So seems like screening works. Again, this is in combination, of course, with advanced improving treatment. And back then, we actually read mammograms quite differently as to what's done now. So this is an old piece of mammography equipment, which predates me. And this is how we used to read them, even during my residency, and even early in fellowship. We still used this bright lit up background. So we could put actual films on, and we used a magnifying glass to look at them. And they looked kind of like this, a little bit not as great as they do today. And now, of course, we have nice modern machines. We have 3D mammography. And this is my colleague, Dr. Philpotts, reading on a nice digital screen where we can digitally magnify everything. And it's much better now. So early detection does matter. So this is some material that's targeted to patients. Some of it is very concise and to the point. And this illustrates how early detection with mammography can help detect smaller cancers. So whereas a mammogram can detect a small cancer about the size of a pea and even smaller than that, whereas a walnut, Brussels sprout or walnut-sized tumor can be detected by a woman herself. So basically, we want to find them when they're this or smaller rather than when they are about this size. So there's also benefits. I know this is a busy slide and I'll explain it in one moment, but there are benefits to screening beyond just mortality. Breast cancer treatment is difficult. It's not easy. So if a small tumor is found early, it's much easier to treat than something that has spread to the lymph nodes or is large in size. And there have been a few studies that actually look at morbidity reduction, so reduction in side effects and extensive surgery, need for chemotherapy. So there were, they compared women who had screening detected cancers, whereas cancers that were detected by physical exam. So on the average, so this was quite an older study, screening detected tumors that were about 1.5 centimeters in size on the average, whereas clinical breast exam detected tumors that were larger than an inch in size. And the women whose tumors were detected by screening were less likely to need chemotherapy. They were more likely to be able to have a lumpectomy rather than a mastectomy. And their lymph nodes tended to not be involved by cancer. Whereas women who had clinically detected larger breast cancers, so again, tumors detected by physical exam, were more likely to need mastectomy, they were more likely to need chemotherapy, and they were more likely to have involvement of their lymph nodes at time of diagnosis. And it appears that women aged 40 to 49 who were diagnosed with breast cancer, who had their cancers detected with mammography, and who had undergone regular mammography, they were less likely to require mastectomy. They were less likely to have positive lymph nodes at time of diagnosis. Again, they were more likely to have smaller tumors, and they were less likely to require chemotherapy. And also the benefit extended into the slightly older group of 50 to 59. This particular study only looked at women 40 to 60. So how do we go about starting screening mammography? By about age 30, women should have a risk assessment that involves talking to your internist or your gynecologist, like Dr. Knudsen, to see what risk factors might there be. At age 40, it is time to start thinking about screening mammography. As I've mentioned already, it does appear that women, if they start getting screened at 40, have the greatest reduction in both morbidity and mortality. What about somewhat older women? So 75 plus. There really doesn't appear to be an upper age limit for screening. So if a woman remains in relatively good health at age 75 and is likely to live another 20 years, she still continues to benefit from screening. And of course, we don't want to force anyone to do what they don't want to do. These are what we're recommending. There, of course, mammography is not perfect. There is potential for what we call false positives, where you may be called back for something that turns out to be benign, or you may even undergo a biopsy for something that turns out to be benign. But it does appear that the negatives are outweighed by the positives. So this is a chart I like to show. So for every 1,000 women who undergo screening mammography, about 100, and actually the number is now less than that with tomosynthesis, and we'll talk about that in a moment, the 3D mammography. So 10% or less will be asked to return for additional pictures. So that we see something that is a potential abnormality, it doesn't mean that it's cancer, but we see something that catches our eye, maybe looks a little bit different from your prior mammogram that we want to take a closer look at. So sometimes that involves just additional mammogram views, sometimes just an ultrasound, sometimes a combination of both. And about 60% of women who are called back will be told that everything looks fine on additional evaluation, return to screening. About 20% will be said there is a finding, but it looks like it's most likely benign, but we do want to keep an eye on it. So we want you to come back in 6 months so we can reevaluate this, make sure it's stable, doesn't change in any worrisome way. And about 20% will actually be recommended to have a biopsy. And about 5 of these women, so out of 5 out of 1,000, will be actually diagnosed with breast cancer. So we'll talk a little bit about, I already mentioned this, but when to stop screening. As I mentioned, there is no established upper age limit for screening. If life expectancy is less than 10 years due to other conditions, severe heart disease, neurologic disease, then potentially can stop screening. But the woman really should make this choice. I'll show you a case. There's an 85-year-old lady who was otherwise healthy, and she had stopped screening about 10 years back. And she came back because she felt a lump in her breast. And this is a mammogram picture, and there is a mass corresponding to her lump in the outer part of her breast. And on ultrasound, we actually see this mass along with some other smaller masses surrounding it, these we call satellite lesions. And under her arm, we see some abnormal lymph nodes. So this patient could potentially have benefited from continuing screening. She was otherwise healthy, and had this been perhaps detected a few years back, she would have had a smaller disease burden. Maybe she wouldn't have had these nodes. So now, of course, she'll be treated, but treatment will be more difficult than if the cancer had been smaller. And at her age, the treatment can potentially be even more difficult than on someone who is a bit younger. So we'll talk a bit about 3D mammography. So at Yale, we've done 3D mammography since 2011. And so I'll show you what it looks like. I hope this works. So not just looking at 2 pictures of each breast, we can actually, the mammogram machine takes multiple low radiation dose exposures through the breast. So we can actually create, we can kind of scroll through the breast. So this is what it looks like. This is kind of what we look at. And if you look carefully, this was actually a small tumor that we found, which would have really otherwise been not visible if we didn't have this nice new technique of 3D mammography. So as with regular 2D mammography, of course, there had to be several clinical trials to prove that this works. And the first large one was in 2013 in Norway, and looked at a large number of patients who had both 2D and 3D mammograms. So 2D is this conventional mammogram, just 2 regular pictures of each breast, and 3D is the tomosynthesis that I just showed you. And they found that there was a 27% increase in cancer detection rate in women who had 3D mammography as opposed to 2D mammography. So significant increase in cancer detection, and more invasive cancers were found with 3D mammography. So these are the type of cancers that have erupted out of the milk ducts and into the surrounding tissue and are mass forming. And also, 3D mammography decreased the callback rate by 15%. So significant decrease in callbacks for potential abnormalities that turn out to be largely nothing for patient. So that's benefits all around. And I'll show you some cases where we were able to detect some tumors as a result of having this 3D technique. So this is a 2D picture. And on Thomas, this is a dedicated slice. I couldn't include too many movies in my talk, otherwise it doesn't work very well. But so you can see this area caught our eye, and I'll show you a close-up. You can sort of see this spidery looking area where the tissue looks like it's kind of centrally pulled in. And this actually was a small breast cancer. Here's a different case. This is a woman who actually does have an elevated risk of breast cancer. You can see her breasts look a little bit different than the priors. And I always like to tell patients, no two breasts are alike. And you can see there's an area that caught our eye again. This area right here, you can see that there's a spidery look again. There's this central pulling in of the tissue. That's one of the things that we look for. And again, the 3D mammography makes this a bit more easily to detect. So this was a small cancer as well. So we'll talk a little bit about breast density legislation and advent of accessory screening tools. In 2003, Connecticut resident Nancy Capello, PhD, received a diagnosis of stage 3C breast cancer. That was metastasized to her axillary nodes, and her tumor was actually detected at the time of her annual breast exam. And incidentally, she had had a normal screening mammogram a few weeks before then. She learned that she had extremely dense breast tissue, which masked her cancer. And she discovered that it was not standard practice at the time for doctors to discuss breast density with their patients. And it was also not standard to recommend supplemental screening if you have dense tissue. And she actually successfully lobbied her state senators to introduce legislation that requires insurance companies to cover whole breast ultrasound as an adjunct to mammography with women with dense breasts. And this bill passed in 2005. And in 2009, the first breast density notification law passed in Connecticut. So this law requires us to communicate directly to the patient, to you, if you have dense breasts or not. And also we say that additional screening is available if wished for. So many of you may have seen these statements in your mammography results letters. So if you have dense tissue, you will find this statement in your results letter that you have dense tissue. This can hide small abnormalities, and you may benefit from supplemental screening such as breast ultrasound or breast MRI, depending on your risk factors. And we also let you know that your physician has been notified, and you can call them if you have questions. So Dr. Knudsen has probably gotten some calls about what that means if you have dense tissue and what should I do. So, and if you don't have dense breast tissue, you have a short and sweet sentence: you don't have dense tissue. So what does that really mean? I'll show you some examples. What we see, what makes us say you have dense tissue. So this patient has a mammogram that's pretty easy to look at, easy on the eye. This darker tissue here is fatty tissue. So everyone's breasts are basically composed of fibroglandular tissue, which is the business end of the breast. That's where the milk is produced and during lactation, and then the fatty tissue, which kind of intervenes. And women have kind of a balance of both, and most of it is genetic. Some people have fattier breasts and some people have denser breasts. This patient, on the other hand, looks quite different. She has a lot of that glandular tissue, that white stuff, and the darker stuff, the fatty tissue, she doesn't have as much of. So I would rather be looking for a cancer in these breasts than in these breasts, much harder. So even with 3D mammography, sometimes in this type of breast tissue, it can be harder to detect small breast cancers. We actually use these density categories, A, B, C, D. So A is fatty breasts, B is some glandular tissue, C is quite a bit of glandular tissue, D is a lot of glandular tissue. So we actually describe this in our reports. And so if you do have dense tissue, if you have this category or this category, you can obtain a screening ultrasound. And you still need the doctor's order to schedule this. At Yale, we do handheld technologies-performed ultrasounds. And these can detect small invasive cancers that are tomosynthesis occult, so not seen on the 3D mammography. So again, just with any other new technique, you want to know results from clinical trials. So one of the first ones was the American College of Radiology Imaging Network study. They looked at almost 3,000 women. These actually were women with with moderately to highly elevated risk of cancer. This was multi-institution, so many different hospitals. And these women received ultrasound in addition to mammography. And in the first year of screening with ultrasound in addition to mammography, 4.2 additional cancers were found per 1,000 women. And after 3 years of screening, they still kept finding some cancers that were not seen on mammography. And these cancers were found at early stage, 89% were lymph node negative. And we were able to reproduce these results at Yale as well. And we actually also included average risk women. So women who don't necessarily have an elevated risk of breast cancer based on family history or known genetic mutations. I'll show you a case. This is a patient who actually has saline breast implants. She's pretty dense. If you have implants, we actually obtain an additional set of pictures. So implants in place and then implants displaced. The technologist literally displaces the implant so we can see more of the breast tissue. And her mammogram was negative, really looked similar to prior years. And on ultrasound, however, there was this very, very small abnormality, only about 7 millimeters. And so we sampled this with ultrasound guidance. We did a biopsy with ultrasound guidance, and this actually showed the form of very aggressive cancer, but it was so small that the patient was able to have her treatment was very relatively well, there's no easy treatment, but had this been found much later, she would have necessitated chemotherapy, and she actually was able to forego chemotherapy. This is another case. Patient had pretty dense breast tissue, normal mammogram. On ultrasound, screening ultrasound, we found this small mass, very small, 5 millimeters. And this was invasive ductal cancer, which is the most common type of breast cancer. Again, and this patient was, I believe, 44. The previous patient was 50. So it is important to know that screening ultrasound does not replace mammography. So it's meant to be used together with mammography because ultrasound findings, many of them still necessitate correlation with mammography, and not all cancers can be seen with ultrasound. So there are some cancers that can only be seen on mammography. Some of the earliest cancers, the DCIS, which is the ductal carcinoma in situ, can only be seen on mammography. I'll show you an example. This is a patient with dense tissue. Her screening ultrasound was actually negative, But on mammography, we saw some little tiny calcifications, so little deposits of calcium in the breast tissue in a little grouping. You can see them here. It's about less than a centimeter in size. And this actually was DCIS, but it already showed some evidence of invasion in the surrounding tissues, even though there was no mass forming. But so this was an early invasive cancer with DCIS, so only seen on the mammogram. Okay, what about breast MRI? Breast MRI was first introduced in the 1980s. It is functional imaging in addition to anatomic imaging, and we'll talk about what that means. There's no ionizing radiation with MRI. And the fundamental idea is that the blood vessels within the malignancy, within the tumor, are a bit more leaky, and they extravasate a contrast agent. So the contrast leaks out of the blood vessels, and that leads to an abnormal contrast uptake in the surrounding tissue that we can see with MRI. And basically, cancers can manifest as masses, or they can look like these abnormal patches of enhancement. So pros and cons of breast MRI. So it's very sensitive, but that means it can potentially detect up to 99% of breast cancers. But it's not the most specific exam, meaning that there is some overlap or a lot of overlap of benign and malignant findings. So there's a higher likelihood of potential abnormalities that we find that can lead to additional biopsies that end up yielding benign results. It also requires injection of a gadolinium-based contrast agent. So that means you get contrast agent injected into a vein. It does take a while to acquire. It's not that quick, 20 minutes. There is what we call background enhancement, where basically just normal breast tissue takes up the contrast, and it can still obscure malignancy or even mimic malignancy. And also, you can't do this during pregnancy because the gadolinium-based contrast agent crosses the placenta, and it can accumulate in the amniotic sac with the baby, and we don't know what it can do in the long term to the baby. So, accessory screening with breast MRI, who should get it? Who should think about it? So, patients with 20% or greater lifetime risk of breast cancer. This can be due to genetic predisposition or history of mantle radiation to the chest. Frequently, it's due to conditions like Hodgkin disease between the ages of 10 and 30. Also, the way this lifetime risk is calculated is based on family history, mainly family history, and of course, also if patient has had some genetic testing that yields clinically significant mutations. So also personal history of breast cancer plus dense breast tissue, or patients who've been diagnosed with breast cancer under the age of 50, or also patients who have had what we call high-risk benign lesions on breast biopsy. Lesions such as atypical ductal hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. If you've had one of these, then you are at elevated risk, and so if you do have a biopsy that yields these lesions, you will be counseled about this. To continue, so high-risk patients, so patients that have either a genetic mutation or significant family history, are also at risk to develop more aggressive breast cancers at a younger age. And paradoxically, some of these aggressive cancers can actually mimic benign lesions on mammography and ultrasound. Also, aggressive cancers are more likely to be interval cancers, meaning that these grow so quickly that they sometimes can show up in a time interval between a screening exam, and I'll show you a nice example. So basically, patient may have a normal screening mammogram at the present and present with a palpable mass that turns out to be cancer, let's say 6 months later. sometimes that still happens. And that is why we also frequently recommend staggered screening for patients at high risk. So alternating mammography and MRI at 6-month intervals. So let's say mammography in June and MRI in December to try to detect some of these aggressive interval cancers. 41-year-old lady who actually had a history of left breast cancer and underwent a mastectomy at age 36. So clearly she's at high risk. She had had a normal screening mammogram 7 months ago, and this was her 7 months ago. She does have dense tissue, and 7 months later, she had a palpable mass, and you can actually see that there's a difference. So she's developed something in this area, which previously was clean before. And she had a fairly large sized tumor, which was brand new from 7 months back, about 2 centimeters in size. And it was an aggressive type of tumor. So MRI takes about 20 minutes to acquire, as I mentioned. This is kind of what it looks like. So patient will lie prone on her stomach. The breasts hang down into the special coils that we use. They're not compressed for the MRI. It's very important not to move. And you do go all the way into the magnet. Arms can be up or down. You can't move during the study. Very important. So we get good pictures. What do we see? So MRI is not a perfect exam. Sometimes you do get a lot of contrast uptake in just normal tissue. So again, kind of a similar problem as to tissue and mammography as well. So I would rather be looking for cancer here than here. So this is a patient that has very little uptake of contrast by regular background breast tissue. These are just blood vessels. And this patient has a lot of background uptake, which can obscure cancers. But again, very helpful in some cases. So this is a 60-year-old lady who has a 27% lifetime risk of breast cancer due to family history, significant family history. This is her mammogram. She had had a prior benign biopsy. There's a clip in here that was normal. Mammogram was normal, but on her MRI, she actually has very little background uptake. This is just part of normal. Sometimes you see these little specks of contrast uptake, all normal, but this looks a little different. You can see here. And we brought her back for a what's called an MRI directed ultrasound, where we look very specifically in the area where we see the abnormality, knowing that we'll most likely find something. And on the MRI directed ultrasound, we saw this small 8mm mass that stood out from the rest of the tissue and appeared to match up with the MRI finding. And we biopsied this using ultrasound as a guide, and it was invasive ductal carcinoma. Again, normal mammogram. Again, as with any modality, you want to see some results from some clinical trials. And it does appear that women at high risk benefit from MRI. So these are the really high risk women, the BRCA carriers. So 26.2 cancers detected per 1,000 women screened. And among high risk patients without a mutation, so patients who have a strong family history or perhaps have these previous atypical biopsies, about 5.4 cancers per 1,000 women screened, and patients who have had a personal history of breast cancer, 10, so meaning breast cancer in the past that's been treated, 10 to 29% per 1,000 women screened. So future directions, what is coming? So potentially ultra fast MRI, so MRI that takes less time, perhaps 8 minutes as compared to 20 minutes. That could be used by patients who have various conditions, maybe cannot stay still for 20 minutes, or potentially for screening more women with MRI who are maybe at moderate risk, but may benefit from MRI. Contrast enhanced mammography, we are working on this to bring this to Yale as well. This seems to have benefits in women who perhaps are at elevated risk but cannot undergo MRI for various reasons. And also coming in the future is increased use of personalized screening recommendations based on individual risk. So how often to screen, with what modality, even more specific than what we have today. Conclusion, mammography saves lives and leads to decreased morbidity of breast cancer treatment. For average risk women, we do recommend starting at age 40 and continuing annually because it does appear to save the most lives and decrease morbidity of breast cancer treatment. Women who are at increased risk of breast cancer due to genetic mutations or family history or personal history of breast cancer may benefit from supplemental screening with MRI, so in addition to mammography. And women with dense tissue without necessarily additional breast cancer risk factors benefit from supplemental screening with breast ultrasound. Thank you. And questions?
You could enter your questions into the chat or the Q&A. Should be located at the bottom of your screen. I just want to thank you, Dr. Andreeva. This was really a great presentation, very thorough, and a lot of great information. Okay, I do have a question coming in. Is there a correlation between dense breasts and hyperlactation?
Oh, not that I am aware of. Women with, in general, there doesn't appear to be a correlation with breast density and basically amount of milk produced. The answer is no, not that I know of.
Mm-hmm. And do you know, is breastfeeding a protective factor or
Yes.
a risk factor?
It is a protective factor, yes.
And yeah, I'd like to add too that exercise and limiting alcohol consumption are additional ways to reduce risk of breast cancer.
Yes, absolutely. Yes. It does appear that especially in menopause, obesity is a risk factor. So after menopause particularly, yes, more than, I believe, a glass of wine or equivalent is a risk factor as well. Glass of wine per day.
Leva, this is Joanne. Is it okay if I jump in with a question, Wendy? Yeah, so Leva, you probably are aware, U.S. Preventive Task Force, for quite a while, they've been had more vague recommendations for women between 40 and 49, kind of saying that was their option, but definitely start by 50 to start screening. But I'm sure you've heard they've drafted a new recommendation. I don't think it's exactly finalized yet, but they are also now leaning towards saying to start at age 40 more strongly. Yes. And I believe it's based on the fact that more cancers are now being detected in that decade of life. Have you heard of this as well?
Yes, so definitely we do see a lot of women in their 40s to 50s. Even on a baseline mammogram, you will sometimes find DCIS, you'll find small tumors, and there does appear to be a somewhat decreased incidence of breast cancer in younger women There's been some speculation of why, but we don't know for sure why that trend is. But yes, so that is, I believe, why the USPFT has adjusted their recommendations. And as we can see, there's quite a bit of evidence that this is the age group that actually benefits the most from screening.
Dr. Knudsen, what do we recommend here for our patients as far as the age to be?
Hi, yes, hi, thank you, Wendy. So we've been following the U.S. Preventive Task Force guidelines. So we have basically been, discussing with our patients to consider starting at least by age 40, but definitely by age 50. And the interval as well could be every year, or some women may opt to space every 2. So we basically follow U.S. Preventive Task Force guidance.
And women don't need a referral, correct?
Correct.
Correct.
Oh,
Yeah,
sorry.
so, yeah, hey, Leva. Yeah, no, so for our patients at Yale Health, no referral is required for a screening mammogram. If someone needs a diagnostic, we need to put in the order for those. We actually have a special arrangement with YNHH Diagnostic Imaging for folks with dense breasts. They do not technically need an order from their physician or clinician. Sometimes there's a little confusion because that's not the case for other insurance carriers. So we are happy to put the order in when needed. But anyway, we're trying to decrease barriers so that people can get the appointments that they need.
Great.
There's a question in the chat. I've had genetic counseling and testing. Do you recommend it for most women with higher risk factors? Yes, in general, I do. So the first point of contact would be potentially your gynecologist or your internist, and they can refer you for genetic counseling. What the genetic counselor does, has a conversation with you. They may map out your family history. So they may ask about your relatives, and they can actually recommend, for or against, say, actually genetic testing.